Hello guys, how are you? I hope so that you will be fine and enjoying good health. Today I have selected a topic on Goodpasture syndrome. Now let us discuss what it is. So as you know that Goodpasture syndrome is also referred to as an anti-glomerular basement membrane anti-GBM disease is an autoimmune disease that affects both the kidneys and the lungs by the formation of autoantibodies that attack their basement membranes. This activity outlines the evaluation and management of Goodpasture syndrome and explains the interprofessional team role in improving care for potentials for patients with these conditions. Now we would come to Goodpasture syndrome refers to an anti-glomerular basement membrane disease that involves both the lungs and kidneys, often presenting as pulmonary hemorrhage and glomerulonephritis. However, some clinicians may interchangeably use several terms including anti-glomerular basement membrane disease, Goodpasture syndrome, and Goodpasture's disease. The anti-GBM disease is the most specific term and refers to the presence of renal and pulmonary involvement along with anti-glomerular basement membrane antibodies. The spectrum of disease may present classically or as glomerulonephritis alone. Goodpasture syndrome is an eponym named after Ernest Goodpasture, who described the disorder for the first time in 1919. Later, the discovery of the anti-GBM antibodies led to a better understanding of the pathogenesis of the Goodpasture syndrome. Goodpasture syndrome appears to result from environmental insults in a person with a genetic predisposition. At this point, a triggering stimulus has not been identified for the development of anti-glomerular basement membrane antibodies. However, there are certain human leukocyte antigen HLA subtypes that have been implicated in conferring increased genetic susceptibility to the Goodpasture syndrome, most notably HLA-DR15. The exposure of the alveolar capillaries to these autoantibodies needs an initial insult to the pulmonary vasculature. These environmental factors include drugs such as LM2 zimomab that cause lymphocyte depletion, inhalation of cocaine, infections such as influenza A2, smoking, exposure to metal dust, organic solvents or hydrocarbons, extracorporeal shockwave lithotripsy. Goodpasture syndrome is a rare disorder. The incidence of the anti-GBM disease is approximately 0.5 to 1.8 cases per million per year in Asian and European populations. It is responsible for 1 to 5% of all kinds of glomerulonephritis. Furthermore, it accounts for 10 to 20% of crescentic glomerulonephritis. Goodpasture syndrome is seen more common in whites than in the black population. However, it may be more prevalent in certain ethnicities such as Maori people of the New Zealand. The syndrome has bimodal age distribution 20 to 30 years and 60 to 70 years. The occurrence of the disease is more in younger men and older women. There is a subgroup of patients that is double positive for both anti-neutrophil cytoplasmic antibodies and anti-GBM antibodies. This subgroup is mainly found in males 60 to 70 years old. Goodpasture syndrome is due to circulating autoantibodies directed at the glomerular basement membrane. The resulting crescentic glomerulonephritis is the result of the antigen-antibody complexes that form at the basement membrane. The autoantibodies activate the complement system in the basement membrane, causing tissue injury. This binding of the autoantibodies can be seen as linear deposition of immunoglobulins along the basement membrane. The inflammatory response in that area results in the typical picture of glomerulonephritis. The alveolar basement membrane shares the same collagen target at that glomerulus. The main component of the basement membrane is type 4 collagen, which can be expressed at 6 different chains from alpha 1 to alpha 6 despite the presence of circulating antibodies in anti-glomerular basement membrane disease. Pulmonary symptoms are not always observed, and inciting lung injury seems to take pulmonary symptoms more likely. In a healthy individual, the alveolar endothelium acts as a barrier to the anti-basement membrane antibodies. However, if an insult results in increased permeability to the alveolar capillaries, it leads to the transpassing of the autoantibodies which can bind to the basement membrane. However, if an insult results in increased permeability of the alveolar capillaries, that lead to the transpassing of the autoantibodies which then bind to the basement membrane. They lead to the transpassing of the autoantibodies which then bind to the basement membrane. The factors that may result in the increased alveolar capillary permeability include increased capillary hydrostatic pressure, bacteremia, tobacco smoking, endotoxemia, exposure to volatile hydrocarbon, upper respiratory tract infections, higher inspired oxygen. Strong evidence for genetic involvement exists, and patients with certain human leukocyte antigen HLA types are found to be more susceptible to disease and exhibit a poor prognosis. An increased prevalence of HLA DR15, DRB1, 03, DRB1, 04 has been found, and in a reduced frequency of DRB1, 01 and DRB1, 07. And Goodpasture syndrome has a strong association with DRB1 15 1501 and to some extent DRB1 1502 allele. However, DRB1 1501 allele is present in one third of people among whites. Therefore, clearly some additional factors such as genetic and environmental are needed for the expression of disease. It is important to note that HLA-B7 is more frequently and indicates more severe anti-GBM nephritis. Although Goodpasture syndrome is regarded as an autoantibody mediated disease, a vital role is played by T cells in the initiation and progression of the disease. T cells cause B cells to increase antibody production and play a direct role in the renal and pulmonary injury. In patients where renal and pulmonary involvement raises suspicion of Goodpasture syndrome, renal biopsy should be considered, which has a better yield than lung biopsy. Light microscopy will show crescentic glomerulonephritis. Over time, the crescent turn fibrotic and frank glomerulosclerosis with interstitial fibrosis and tubular atrophy may be appreciated, and immunofluorescence will show the linear deposition of IgG and complement C3 along the basement membrane. Predominantly subclass IgG1 is present. A kidney biopsy is not only crucial for diagnosis, but the percentage of crescents identified on biopsy confers renal survival prognosis. Lung tissue is typically not sought due to the invasiveness of the procedure and a more difficult immunofixation process for lung tissue. Lung biopsy, when performed, shows extensive hemorrhage with deposition of hemosiderin-laden macrophages with alveolar spaces. Patients with Goodpasture syndrome will initially present similarly to other forms of rapidly progressive glomerulonephritis with acute renal failure. There are no symptoms specific to the anti-glomerular basement membrane that distinguish it from other diseases causing similar organ dysfunction. Careful and expedient workup must be undertaken for an accurate diagnosis. Their pulmonary symptoms are typically present at the time of initial encounter or shortly after that. Hemoptysis of varying degrees is typical for pulmonary involvement, ranging from serious and life-threatening bleeding to more subtle diffuse hemorrhage that is only apparent on more careful evaluation. It is more typical for younger patients affected by anti-glomerular basement membrane disease to present with simultaneous renal and pulmonary symptoms, Goodpasture syndromes, and to be critically ill on presentation. Patients over 50 years old tend to present with glomerulonephritis alone and follow a less severe course. Careful physical examination of patients presenting with findings suspicious for the anti-glomerular basement membrane disease should be done, particularly for other signs such as sulfuric rash. This finding may suggest so-called double positive patients with concurrent ANCA associated vasculitis, granulomatosis with polyangiitis. Other physical exam findings to look for in Goodpasture syndromes are increased respiratory rate, basilar inspiratory crackles, cyanosis, and hepatosplenomegaly, hypertension, in 20% of cases edema. A kidney biopsy is the gold standard for diagnosis, but it is not required to begin treatment or continue therapy if a biopsy is not feasible. When performed, biopsy provides important information regarding the activity and chronicity of renal involvement, and that may guide therapy. Percutaneous kidney biopsy is the recommended procedure to establish the diagnosis of Goodpasture syndrome. Kidney biopsy is preferable over lung biopsy as it provides a much higher yield, but lung biopsy may be performed where renal biopsy is contraindicated for any reason. The biopsy tissue should be sent for analysis under light microscopy, electron microscopy, and immunofluorescence. Light microscopy shows non-specific findings of a proliferative or necrotizing glomerulopathy with cellular crescent as shown in the image. The crescents become fibrotic over time, leading to the development of frank glomerulosclerosis, tubular atrophy, and interstitial fibrosis. Immunofluorescence stains are more specific and diagnostic, and these exhibit bright linear deposits of immunoglobulin G, IgG, and complement 3 in the glomerular basement membrane. Serologic testing for ELISA assay for circulating anti-GBM antibodies should be done immediately on suspicion of the disease. Specifically, it is essential that the alpha-3-NC1 domain area of the collagen 4 be used as the target in this assay, as false positive may be seen in less specific testing. Quantitative titers are followed during treatment phases to guide treatment decisions. Urinalysis is characteristic and usually demonstrate low-grade proteinuria, gross or microscopic hematuria, and RBC cast. A complete blood count may reveal anemia, secondary to intrapulmonary hemorrhages and leukocytosis is generally present. Renal function test may be deranged secondary to renal dysfunction. A chest radiograph shows patchy parenchymal opacifications, which are usually bilateral and bibasilar. The Pisces and costophrenic angles are generally spared. Pulmonary function test shows the elevated diffusing capacity for carbon monoxide DLCO secondary to binding of carbon monoxide to intraalveolar hemoglobin. Patients presenting with Goodpasture syndrome, both glomerulonephritis and pulmonary hemorrhage, may be critically ill on presentation, and urgent hemodialysis often is needed for standard indications, and intubation for respiratory failure may be necessary. When the clinicians suspect the diagnosis, a kidney biopsy should be done as soon as possible, as the clinical situation allows. Upon diagnosis, patients should be started on prednisone, cyclophosphamide, and daily plasmapheresis to improve overall mortality in general and renal survival in particular. Therapy can start before the patient progresses to needing renal replacement therapy. The overall renal prognosis is better. All patients with pulmonary symptoms should be started on combined therapy regardless of their renal status. For patients without pulmonary symptoms in home, renal recovery is very unlikely. For those that presented with urgent need for dialysis within the first 72 hours, the risk of plasmapheresis and immunosuppressive may outweigh the benefit. The choice to withhold treatment in these cases remains controversial, as the disease has not been well studied in controlled trials. It remains difficult to predict who in the group exactly will respond and recover renal function. The overall return of renal function in this group is approximately 8%, yet many clinicians still opt for a trial of aggressive combined therapy at this time. Typically, daily plasmapheresis is performed until anti-glomerular basement membrane antibodies are undetectable, with steroids and cyclophosphamide continuing for after that for 3 to 6 months until full remission is achieved. This can be gauged by checking repeated titres following plasmapheresis, as well as any time new symptoms develop that could be a harbinger of relapse. Overall, relapse remains rare. The starting dose of cyclophosphamide is 2 mg per kg orally adjusted to keep a white cell count of approximately 5,000. Treatment of acute life-threatening alveolar hemorrhage is with IV methylprednisolone pulse therapy 1 gram per day for 3 days, followed by a tapering dose of 1 to 1.5 mg per kg orally. Rituximab has been found to have a role in some studies in which the conclusion was that it led to the undetectable levels of anti-GBM antibodies. What is the differential diagnosis? All the pulmonary renal syndromes that affect the lung and kidney are to be considered in the differential. These include granulomatosis with polyangiitis, which is vaginal granulomatosis, systemic lupus erythematosus, and microscopic polyangiitis. Some patients with Goodpasture syndromes also have ANCAs positive, which makes it difficult to distinguish it from granulomatosis with polyangiitis. Some IgA-mediated disorders also present with pulmonary renal syndrome, such as IgA nephropathy and hematuria purpura. Other differential diagnoses include acute glomerulonephritis, community-acquired pneumonia, granulomatosis with polyangiitis, pneumocystis jirovecii, pneumoniae, and Churg-Strauss syndromes. With the development of aggressive therapies such as plasmapheresis, corticosteroids, and immunosuppressive agents, the prognosis of Goodpasture syndrome has significantly improved. With these therapies, the 5-year survival rate has exceeded 80%, and less than 30% patients require long-term dialysis. However, delayed administration of cyclophosphamide has been found to be associated with a fatal prognosis. Even with appropriate treatment, kidney function may be impaired to the point of failure. While kidney failure is a relatively common complication for patients with Goodpasture syndrome, less than 30% of surviving patients require long-term dialysis. In severe cases, a kidney transplant may be necessary. A nephrologist should be consulted for the evaluation of a patient in terms of differential diagnosis of the renal disease, indication of renal biopsy, and requirement for hemodialysis plasmapheresis. As these patients may present with serious and life-threatening pulmonary complications, a pulmonologist should be consulted to guide therapy. A surgeon's assistance may also be needed when vascular access is needed for hemodialysis or plasmapheresis. Patients should be made aware of the treatment options available. Many immunosuppressive medications have various adverse effects that patients should know about. They should be educated on when to seek medical help in order for management to happen sooner than later. In some patients, it recurs, so giving patients a basic knowledge of how to pick signs of Goodpasture syndrome may help them pick a relapse quickly and seek help. The prognosis for this spectrum of disease is overall good, provided the disease is identified efficiently and treatment is started promptly. Overall survival and renal recovery track along with the degree of renal impairment on presentation. Recurrence is rare but possible, and patients typically do well with recurrent episode. This is most likely due to heightened clinical suspicion. Treatment in recurrent cases is identical to the initial episode. Patients that do not recover renal function and remain dependent on renal replacement therapy may qualify for renal transplantation. Anti-glomerular basement membrane antibody titer should be negative for at least 6 months before transplantation. These patients rarely experience recurrent disease in the current era following transplant, but it has been reported in the literature, it has been theorized that long-term use of immunosuppressive agent intended to protect the graft from rejection simultaneously keeps the autoimmune disease from recurring. So management of Goodpasture syndrome requires careful coordination of several specialties. The involvement of pulmonary, critical care, nephrology and rheumatology should be sought depending on the spectrum of clinical findings and the severity of the disease. An interprofessional team consisting of clinician, nurses, practitioners, physician assistants and pharmacists will provide the best results. For plasmapheresis, if indicated, should be sought. Initial labs assays should be expedited and protocols should be put in place for all team members to be aware of positive test results and act on them immediately. So it was all about the Goodpasture syndrome. I hope so that this video will be more informative for the audience, and I hope so that you will share this video with the other individuals as well. And if you have liked this video, then kindly subscribe my channel, and thank you for listening this video. Have a wonderful nice day.